Hi there everybody and welcome back. Sorry you didn't see the Pilates video due to time constraints. We've just run out a little bit of time today. It will be on the website so you can look at that later on. So welcome back, as I say, and it's session 3, which is symptom management. We've got 3 speakers this afternoon. I do appreciate that you've been here for a wee while and it's the end of the day, but I think Ailey at the end has got some exercises for us to do to keep us all going. So first up, we're going to hear from Laura McNaughton. She's a plural clinical nurse specialist in Glasgow, and this is on symptom management. So we're talking about breathlessness, and she's going to talk about long-term chest drains, in particular indwelling pleural catheter, and I'll hand you over to Laura just now, and then we'll have some questions at the end of her presentation. Thank you, Laura.
Good afternoon. I'm just waiting on my... Use that. Oh, good afternoon. Thanks, Jane. I'm Laura. I'm one of the pleural nurse specialists based at Glasgow. And I'm going to talk to you today about indwelling pleural catheters. What we're going to look at first is malignant pleural effusions and a wee bit of information about how we would manage them. Then I'll go on to discuss what an indwelling pleural catheter is, why we use them, how they're inserted, and finally a wee bit of troubleshooting. So patients with malignant pleural effusions often present with increased breathlessness, chest pains and fatigue. This is due to fluid building up in the space between the lung and the rib cage. First of all, we can look at improving the symptoms and understanding why the fluid's there. And we can do this by aspirating some fluid, which is a simple procedure where we place a thin catheter in the space between the ribs, attach it to a bag and drain maybe 500 ml or a litre. This allows us to send the fluid away for some sampling and also to improve the symptoms with immediate effect. This, however, does not provide long-term symptom management, and often the fluid does recollect back into that space. To stop this from happening, we might consider inserting an intercostal chest drain. This requires a couple of days in hospital. It's a wee bit more invasive than having just a simple aspiration. This procedure is often done by a respiratory doctor or a specialist nurse. The patient would come into hospital, have an ultrasound performed in a safe space identified to place the drain. Then a small thin tube would be placed in between the ribs into the pleural space, sutured into place and attached to a bottle. This allows for the fluid to be drained over a couple of days and allows us to recognise whether the underlying lung is going to reinflate into that space. This happens in about 75% of people, and once the lung is re-expanded and the fluid is all drained away, we can put in some sterile talcum powder, which acts as a glue, sticking the lining of the lung to the lining of the rib cage. This procedure is successful in about 80% of people and allows for that fluid to be managed and to not reaccumulate, providing the patient with symptomatic benefit. In the patients where this procedure is unsuccessful, or as I explained earlier, where the lung doesn't fully re-expand up into the space, or in some patients where they don't want to be admitted to hospital even for a short time, like a week, we would consider placing what we call a permanent catheter, an indwelling pleural catheter, and that's what I'm going to go on to discuss with you this afternoon. So what is an IPC? It's a soft, short, flexible tube which we tunnel under the skin and drop into the pleural space, the fluid. On this picture here, you'll see that a section of the drain is left out from the skin and lives under a dressing when it's not in use. This picture shows us the small fibrous cuff which is tunnelled under the skin and holds the drain in place by causing some scar tissue around it. The black arrows show us the holes that sit in the fluid and allow the fluid to be drained away whenever required. And this white valve, which is circled, stops any fluid from leaking out of the space and is attached onto a bottle to help drain the fluid. Sorry, my slides aren't going. So why use indwelling pleural catheters? So in patients where talc pleurodesis in a chest drain hasn't been successful, or where accumulation of the fluid is too quick, or they have trapped lung, it provides excellent symptom management, improving quality of life and reducing breathlessness and pain. Some patients don't like the thought of being admitted to hospital, and so this allows for the fluid to be managed at home. District nurses can often visit the patient every day if required to drain the fluid, and they can also help in training family and friends in managing the catheter for the patient. This allows the patient freedom to be out and about and live their day-to-day life without really burdening symptoms. It allows patients to go on holiday and to spend time with their family. In patients where a chest drain hasn't been successful, it also reduces hospital visits and having to come to hospital, have a drain inserted and fluid drained away. And drainage can be tailored to the patient. It's all about them and their symptoms, and so one size doesn't fit all. So inserting a pleural catheter can also sound quite overwhelming and quite intimidating and a bit scary. It can be done by specialist doctors, pleural nurses, interventional radiologists, and is done often as a day case where the patient can come in the morning, have the drain inserted and go home later on that day with all going well. The procedure will be performed with the patient lying on the opposite side from the effusion. An ultrasound can be performed to identify exactly where the drain will go, and then the procedure is done completely sterile with lots of cleaning solution and sterile drapes, and the performer, the person performing the procedure will be all sterile as well. 2 small incisions are made, which is what you can see in this picture. One in which the tube is dropped down into the pleural space, and the second where the tube comes out. And in between there is where that wee fibrous cuff causes the scarring tissue which holds the drain in place. Once the drain's in, some sutures will be applied just to hold it in place for a couple of weeks. But once it's in, some fluid will be drained, maybe 500 ml to a litre, and then the drain will be put under a dressing. With this all going well and the patient feeling well, they would be able to go home later on that day after an x-ray just to confirm there's been no complications and that the drain is in the right place. So this picture here shows you the drain under the dressing. It's really discreet, and if I had one just now, you wouldn't be able to see it under my jumper. Once the drain's in, the district nurses can come out often to drain the fluid and redress and make sure that all wound care is performed. After a couple of weeks, those sutures that are around the drain and closing the drain entry site can also be removed. And the drain can be quite comfortable at this point. You'd be able to lie on that side and sleep without feeling it too uncomfortable. Things that are really important once the drain's been inserted is to keep the drain clean and dry and make sure that the dressing's on secure to reduce the risk of infection. This also protects the drain from being pulled or falling out. One thing we do advise is that we avoid submerging the drain in water, so things like swimming and bathing can become a wee bit difficult and should be avoided. But after a couple of weeks of the drain being in, having a good shower isn't advised. So finally, it's probably good to look at how long an IPC can stay in and why we would choose to remove it. An IPC can stay in forever and is a really good tool for managing the build-up of fluid and breathlessness caused by this. Although in some cases, by keeping that space dry and draining all the fluid away, the space sometimes auto-pleurodeces or the fluid stops collecting in the space, and that means that the drain can be removed. Removal of the drain does require low drainage for a number of weeks, maybe 4 to 6 weeks, depending on your clinician. And this is just important because we don't want to remove the drain too early, and sometimes the drain does recollect slowly, and what we want to avoid is recurrent procedures. Removing the drain is really, really simple and would be discussed with you at the time it was to be removed. So with an IPC, everything comes with its own issues, and we want to be able to manage these and have a bit of an understanding of what the possible problems could be. So one thing we see quite often is pain on drainage, and it is important that you discuss this with your clinical team. It might be that you need less drainage or that you need some painkillers before you start draining your drain. Another risk is infection, so making sure to maintain a clean drain and a sterile drainage technique and making sure that dressing is always on securely is really important. If you have an IPC in situ and you're worried that you have an infection, it is important to discuss with your GP or your clinical team, and you might need an antibiotic. These drains are a piece of plastic and they can become snapped or broken. If this was to happen in your dressing pack, there is an emergency clamp which can be attached above where the snap or the break is, and you should attend A&E or contact your clinical team if they're available to have this looked at and possibly have the drain removed or fixed. These drains do become blocked. They're draining fluid away from that space, and sometimes wee bits of gunk and tissues and things can get in them, which can cause them to block. And again, you can contact your clinical team. There are medications that can be used to unblock these drains. And again, it is important just to recognise these issues and react to them as quickly as possible. And although your dressing might be perfect, sometimes the drain can become dislodged or the drain can fall out. Again, it's a case of attending your doctor and having it reviewed and looked at. But I think overall IPCs are safe, really effective ways of managing pleural effusions and breathlessness and making sure that patients are comfortable and can live at home. And I'm an advocate for using them. What have I attached on here? Sorry. Is just some useful links for information. The Meso UK website, the Scottish Mesothelioma Network, and one resource that I really enjoy using is the Pleural Effusion Journey, which talks you through all of these options that I've discussed today and the use of IPCs. I'd just like to thank the Scottish Mesothelioma Network for inviting me here today to talk, and if you've got any questions, I'd be happy to answer them.
Thank you very much, Laura. That was very good, very useful. I know not
Thank
all of our patients with mesothelioma have pleural effusions, but a good significant number of them do. So I'm sure that some of our patients, this will be very useful information, and maybe some of them have them. Um, Interestingly enough, I have no questions coming up in the chat bar so far. I know that you and I both put in these long-term drains. I think from the patients in the Highlands point of view, we probably put more in than the traditional drain that you spoke about at the beginning, where you have to come in as a, and stay in for a few days, because often people are in the process of being diagnosed, or have been diagnosed generally, and just don't want to be in hospital, especially from the distance. Some of our patients come from quite some
Mhm.
distance away. So we sometimes put the long-term drains in, and I don't know if you're doing it yourself, but we find that with when you take the fluid out, you've spoken about it a little bit there about the autopleurodesis, that it'll stick together itself if we keep the
Mhm.
area dry. But also we know if we get to the stage that there's very little fluid, that we can put the talc down the drain itself as
Mhm.
well. Um, so I don't know if you find geographically, if it's people who are further away, do you find that more of them want the long-term drain in rather than having to stay in hospital?
Oh, so I'm always a wee bit shocked at who chooses the long-term drain and who chooses the hospital admission. I think
Mhm.
having the IPC plus and the talc, being able to put the talc down the IPC has probably made a difference to the number of people who choose an IPC. In Glasgow, I would say the big thing that affected people's decision was COVID and not wanting to be admitted to hospital due to COVID,
Yeah,
rather than wanting to be at home over
mhm,
wanting to try a chest drain.
yeah,
But yeah, it's total preference, and um, I think IPCs are great, and so are chest drains, and we have to really just be directed by what's so important to the patient and where their priority lies, um, over geographical location. And
yeah,
that's kind of how I always drive my discussion, what's important to
yeah.
them.
And I think that's I think maybe something that's not specific to Highland, but in Scotland quite specific to Highland is a lot of the patients, that's just they don't want to come the distance. It's not
Yeah,
it's geography, but that's their choice, isn't it? And it's very much in
yeah.
choice. And as you say, the my pleural effusion journeys are just such a valuable resource as well, and quite
Oh,
often point people to
absolutely.
that. Yeah.
Yeah,
And I
definitely.
don't know how much you see, but our district nursing teams are fantastic, and quite often if it's a problem with the drain, they'll refer back to myself and the team. They'll just drop us an email and say, this is the issue, because the GPs aren't so experienced with them as we are with the team. I'm not sure how often you see that, but
Mhm.
the other thing as well is that we've got some of our district nurses will support family members to do the drainage, so that sometimes when if they're well otherwise, especially once they get the fluid off, they're like, this is great, I'm back doing loads of things again, I'm not so tired, I'm not so breathless, and they're wanting to be out doing things, and then they're like, oh, I would like to play golf, but the district nurses have to
Yeah.
wait in for the morning. It's not the district nurse's fault, it's just um, on how busy they are. But I notice that they quite often, we've had some families doing it so that they're not, they can go on holiday themselves because the family will do the drainage and
Yeah.
that. Do you see much of that as well?
Yeah, no, I definitely have noticed it more in, especially where younger patients,
Yeah,
they definitely are more keen to have their family trained up, and families seem to be really receptive, and actually probably because they care about the patient a wee bit differently, are actually maybe better at managing it and better at recognising, oh, there is a wee bit of a change here, or that fluid's a different colour, or which
yeah,
is it's empowering for the patient and the family, I think, to
absolutely.
be able to provide that support. But yeah, it's definitely
So
something I've seen
someone's
more of.
actually asked that question as we started on it. Someone's asked that question: how many of the patient's family members take on the drainage, and what training's available? So I know we have a slightly different model, but how does the training for families? Who does that when from Glasgow? I know it's everywhere in Scotland, so
Yeah.
you're just getting the take of us two at the moment, but
I know. So I try and do one with the family myself, but Jane, we're lucky to have a service, the plural nurse. It's not
Mhm.
everywhere. So
No.
it's completely understandable that you don't have that support everywhere.
Mhm.
But other things are like the Rocket Medical, My Pleural Effusion Journey. They all have online videos that are step by
Yeah.
step. And often our district nurses are more than happy as long as they feel confident and they're happy to pick up the phone to you and talk you through it before talking the family through it. But yeah,
Absolutely.
as it's different everywhere. But there are good
It's funny we don't often
resources,
have
YouTube
these.
videos.
Yeah, it's quite
Sorry.
interesting because we quite often have conversations about things, but not often have enough time to have conversations about this. But it's good to know that we're,
Yeah,
even though we're, that we're doing that similar things being done in
yeah,
Scotland. And you're right, not all areas have a plural nurse. I know Aberdeen do, and I think Edinburgh do now.
yeah,
But we're very fortunate, very fortunate.
definitely.
I don't think there's many other questions coming up there actually, which I was quite surprised about. I did
Mm,
notice as well, we talked, you had a brief mention there on pain, on drainage, and obviously that's a big thing for anyone, but in the mesothelioma, and I think that some of our patients find that because there's suction in the drainage bottle, there's a
mm,
wee bit of suction there that sometimes you're right. Again, that's back to the family, but sometimes the family, and not that just nurses are not patient, but the family will be very aware of, okay, so about now he gets sore, or she gets sore,
yeah,
and sometimes just easing off the drainage with
yeah.
the valve might help.
Tailored one size doesn't fit all, does it?
No, no, not at all, not at all. That's super. Thank you very much. Unless there's anything else
Yeah,
you want to add, we're just about on time, just about catching
no,
up.
that's
If there's
perfect.
any other questions, we can. If there's any other questions after the next two speakers, we'll come back at the end if that's okay with you.
Yeah, perfect. Yeah. Thanks,
Superb.
Jane.
Thank you.